Thank you for joining us, everyone. We're just waiting. We're going to wait for another minute or so to have more participants join us. Just a minute or so. Thank you, everyone. We're going to start the webinar now. A very, very warm welcome to all of you. Thank you very much for joining us today for a webinar on India's progress on family planning, highlights from NFHS-5. This is hosted by Advocating Reproductive Choices Coalition in collaboration with Population Council. I'm Prerna Puri, Manager, ARC Secretariat. ARC is a coalition of 113 organizations working towards expanding contraceptive choices, improving quality of care, and ensuring availability, accessibility, and affordability of reproductive health and family planning services. Population Foundation of India is currently serving as the ARC Secretariat. We will begin this webinar with a presentation on NFHS-5 findings on family planning, followed by a panel discussion and a round of question and answers. We request you to please share your questions with the speakers in the question and answer box down there. A quick note before we begin, the webinar is being recorded and I hope there are no objections to that. Without further ado, I now request Dr. Niranjan Sagurati, General Body Member of ARC, Country Director of Population Council, to please share his analysis of family planning trends from NFHS-5. Niranjan is a public health researcher with more than 2 decades of experience in ASAR-HR and population issues. Over to you, Niranjan.
Thank you so much, Prerna, for the kind introduction, and good afternoon, everyone. And it's my pleasure to present the work on the family planning in 36 states and union territories where we have data from the fact sheets. And I'm only representing my team to present the findings, but this is the work that was done by the large team because we wanted to kind of pull all the information that exists in the fact sheets and then make sense of the information, the analytical plan, and what the learnings, and really interpreting the data that's coming out. It has been a big tough task, and within say 10 to 15 days from the release of the fact sheets, we could put together a slide deck which I hope will be informative to many of you. So just as a brief, the NFHS-5 summary data is available on 36 states. There are 12 indicators on family planning and 17 indicators on maternal delivery care, 18 indicators on child health, But we haven't analyzed all those indicators in the current presentation, but we have actually chosen some of the maternal and child health indicators to really look at the relationship that it has with family planning. And there are three elements that we carefully looked at from the data. One is on what do we make out of this whole increase in family planning? And second is what changes and the trends that are emerging on the fertility and also on the MCPR. Have we done enough? Do we need to do more? Is the business over? Or is what does the future look like for the family planning? Those are the key questions that we have asked ourselves when we were looking at the data. So from that context, I'll present both the learnings from the data and also the way forward for the family planning program in the country. Before I start presenting the results, there are 3 pointers that I would like to highlight. One, that it's all the insights based on analysis of data for indicators available in the fact sheets. So analysis is mostly restricted to 640 matched districts between NFHS-4 and 5, because we were trying to compare what the changes have been between the survey rounds and how do we make an interpretation of from those changes that we are observing. The second pointer is that it actually explains the associations and not the cause and effect unless specified. And there is more raw data that is required to examine the cause-effect relationships, why there are certain things behaving in certain way. There is more data that is required, and when NFHS-5 raw data is available, there will be a lot of that analysis that will go on as part of the Rasta Initiative. The third pointer is that analysis presents the learnings and way forward. So it doesn't say that those are the only learnings, that is the only way forward, but it's an indication based on what's emerging from the data. Just want to make sure there is some, yeah. So this is the trend in MCPR and TFR. This graph looks amazing, given the fact that there is a 55% increase in MCPR in the last 28 years. And so is the corresponding decline in total fertility rate, about 41% decline in total fertility rate. And what we take a note of is that from NFHS-4 to 5, a substantial increase that is noted. It may be that there is something that went wrong here, something maybe here, but the one good factor out of this is that there is a substantial increase in contraceptive prevalence rate over time, which is also explained by the fact that the total fertility rate has actually reached the replacement level in many of the states or countries, across the country. And this is the a snapshot of how different states fare on fertility. Like you can see from the graphs here that about only 5 out of 36 states had TFR over 2.1. And 31 states were already below the replacement level fertility, and 11 states, and that's my pointer to the program, that the 11 states had TFR 1.6 or below. And for example, Sikkim, if we take, it has as low as TFR as 1.0. And we also saw the negative population growth in case of Sikkim. So before these states have very low fertility, and that they move to the aging process as a part of the population dynamic, we need to do something as part of the family planning program to make sure that there is that we consistently maintain. Otherwise, we'll go into the state where China is right now, when they're encouraging more and more children to in the country. So, and also at the same time, the family planning FP 2020 goals, if we look at where is India, the first goal was increase the modern contraceptive prevalence rate to 54.3. And the goal, from the data, it appears like we have actually reached the 56.5%. which means that achieved, and also on that met demand of family planning to 74%. Data suggests that it actually is 74.2%, which means achieved. On the goal on 48 million additional users, the magic number that many of us know, for reaching by 2020, we don't have actually the estimates or calculations, but that's work in progress. And at some point, this number didn't matter at all, but it is more about the universal access to family planning services. But if we go back and do the number calculations, my assumption is that with the 56.5% MCPR, we are well at that number. And on the other hand, the current levels of family planning and change at state level, if you see, in NFHS, the data shows increase in MCPR is primarily driven by the increase in modern spacing methods. Specifically, the condom use has increased substantially in many states. And the other new method, which is the injectable, although the overall prevalence in many states is well below 1%, but it had a threefold increase from the previous round of survey. There exists that promise, but to take that to a higher level, much more effort that is required. And sterilization is increased by only 2%. It's very nominal, and there is no change in male sterilization. But what we have noticed from the NFHS data is the whole increase in the use of traditional methods. And we will see what may be contributing to the increase in traditional method in the data. For example, before we further went into the in-depth analysis of the data, we looked at what may be the quality of data for MCPR in NFHS-5 at state level. So if we look at that data, during 2005 to 16, 17 states or union territories showed decline in use of modern method. But in the last 5 years, most of the states had a substantial increase. And that huge change in some of the states within a short period could be because of the intensive program effort, which we need to commend the efforts of the program, or data error in previous round of the survey or the current survey round, which needs some more additional analysis of the data. We are not conclusive in this interpretation. The only point that we are saying from the right-hand side data, if we look at an annual rate of change in MCPR of anything above 3 is questionable from the point of view of the data. Let me remind you all, I'm researcher, and we are only saying what data is suggesting. So it's not about what has been the quality. We didn't examine actually the quality of the data. The only if we look at into the history of this family planning program, the only state which actually achieved that 3% annual rate of increase was Andhra Pradesh in early 2000s. And there was a huge sterilization camps and the program that happened in the state, and which had seen, even with a very low female literacy, the fertility coming down, the contraceptive use increasing substantially in that state. On the other hand, the current level of unmet need and change, again, it has declined between the survey rounds by 4%, and half of these were for modern spacing methods. But still there exists a high unmet need in about 14 states, which is above 10%. And more than 5% of the unmet need for spacing in many states, which actually requires the attention. And the other good result that comes out of NFHS-5 is where the state's performance in meeting the family planning demand has increased substantially. There is a huge increase that has happened. For example, in comparison, there are more states now showing the 75% demand satisfaction by modern methods, and there are less number of states below 50%. and at the border of that 75%, there are substantial number of states, which actually suggests that the states are catching up in terms of the meeting the family planning demand, but there exists some variation, and that variation, and despite the modern spacing or reversible contraceptive methods increase, why the demands satisfied by modern method remained at 75% is because of that increase in the traditional method use. So one of the hypotheses or the questions to be tested when the full data is available is to see the proportionate increase in the traditional method use that is attributed to the discontinuation of the modern reversible contraceptive method. And that's something that a future kind of a research research question. And when we look at the change in the determinants of that contraceptive use, and before going into all those determinants, we looked at also the change in MCPR at district level. There are a number of districts with MCPR of 60% plus, and that increase has been substantial between the survey rounds. For example, from 130 districts, which actually had 60% plus in 2015-16, now moved to 242. Similarly, at the same time, districts which shift from low MCPR of less than 45% to greater than 45%, which actually requires a sustained program effort. But on the other hand, there are 104 districts in different parts of the country that requires intensified program plan because the MCPR is still below 45%, which means that there is now the program has to think more in terms of the focusing on those districts where the performance of the program has not been still requires more attention, but at the same time sustaining the program gains that have achieved during the 2 rounds of the survey. And what has changed? Why there is that substantial change? Mainly because there is an increase in the 10 plus years of schooling for girls, and there is also that the child marriage has declined in many states. Adolescent childbearing has witnessed decline, although I'll come to the points about the adolescent childbearing and child marriage, as well as the schooling and how they're all interlinked, and why there is a need to focus still, because they're not at the optimal levels at the moment. But there is also an increase that we saw in the maternal health indicators. On the ANC checkup in first trimester has increased substantially in many states. And 4+ ANCs also has increased, but 4+ ANC is still catching up. There is a substantial increase that we saw, but still catching up. And the postnatal care, in NFHS-5, we saw that postnatal care, family planning discussion during the postnatal care actually helps the couples to adopt the contraceptive method. And what we saw was that that increase in the postnatal care, which we assume, and we have examined the data to see whether that association still holds. The other interesting finding was the FP program coverage and change between 2000, from 2015-16 to 2019-21. And this was the amazing thing that has happened, because one was that it's the health worker outreach to the female non-users for family planning, which is a proxy indicator to know the extent or the intensity of the program coverage in those districts. And then the other is the users were told about side effects, which is a proxy indicator for the quality of care, one of the key indicators of the quality of care. And we saw across the states and even in the districts. I'll show in the next 2 slides what the district data tell us about it, but across the states and across the districts, with exception to few districts and few states, the increase otherwise is in the positive direction. And this is what I was saying, that the family planning service coverage at the district level, what we saw was almost an increase in many districts. The dots that you're seeing above the red line, all those districts have witnessed a change. And long known hypothesis is that increase in frontline health worker contact can actually help in behavior change among couples about contraceptive use. However, what's affecting low coverage in some of the district is unknown empirically, which means I'm talking about what is happening to the districts that are below this red line, and why is that there is a decline, and that why we are counting on this decline is because still the female, the outreach worker meeting the female non-users is not substantial or optimal at optimal level. On the other hand, the quality of care indicator, the current users ever told about side effects, there was a substantial improvement. And then we did a multivariate analysis to actually understand how is this change in the contraceptive use from NFHS-4 to NFHS-5 is affected by the change in all those determinants that we saw in the data. We took several variables, including the maternal health indicators and the education of the woman, which is there in the below the table. And what data tells us, these results tells us, is that the districts with increased health worker outreach to female non-users on family planning, also the districts that have witnessed substantial increase in MCPR. So there is that strong correlation between the change that is happening in the family planning coverage indicator to the change that is happening on the family planning outcome. And similarly, the districts which have seen improvement in maternal health coverage indicators also witnessed. So there is that the change it looked like there is an overall connection between how this program coverage indicators and the outcomes are behaving. And that's a very interesting. And then we looked at what actually is making that difference and what is that pathway to change and which is that variable that is significantly affecting that change in the MCPR. So we did the decision tree analysis to understand what actually is happening. And as per the data, districts with significant improvement in program coverage and quality of care, they were identified to be the key factors in improving the MCPR from NFHS-4 to 5. For example, from this analysis, what it shows us is that even the maximum average change in MCPR from NFHS-4 to 5, it's estimated to be 23% in the districts where there was over 7% change in health worker contacts with non-users, and over 19% change in the institutional delivery or even in other indicators. So that's the kind of these results state that there is wherever there is that increase that noted in one indicator to a certain level, to the another indicator to a certain level, that's where the change in the whole MCPR that was seen. And when we looked at we did the analysis to understand whether the MPV district program strategy, did it work? And results suggest that it seems it has worked. In some way, the data now indicates that, for example, if you look at all the program input variables, in the case of MPV districts, there was a significant increase than those non-MPV districts in MPV states, and also are compared with all districts in the non-MPV states. And that increase is substantial for many indicators. And the most interesting and important indicator from the context of this presentation is the average MCPR, which has increased a substantial change that is noted in the MPV districts as compared to the other districts in the whole country. And that change was also substantial in case of reducing the unmet need. If you all remember, when we presented under the Rasta Initiative in 2017-18, we did this analysis to show that how much the health worker talking to female non-users matters in terms of changing that MCPR or improving the MCPR. And what we did was we took those districts and examined those closely with NFHS-5 district level data. And those results are here. And what this result clearly state, if we place the health worker talking to female non-user and look at that range less than or equal to 30% in the current value of NFHS-5, and how many districts are there, what was the average value of on this indicator in NFHS-4, and what is the average value on this indicator in NFHS-5. Similarly, the same analysis was done where the value range is over 50%. And what was the average value in NFHS-4? 20% increased to 57.3%. And when I go back, I say that 18% to, if it increases to 50%, the MCPR could go up to 68%. And that is what we see here. Among the districts which reported health worker outreach of 18% in NFHS-4 and moved to 20% in NFHS-5, and which is this part, there is only relatively a small change in the MCPR. Whereas when we look at the contrast category of where that has moved from 20% to 57%, for example, the MCPR even went up to 71% in those districts. And even with the change of about 20% in the health worker outreach to the non-female users, the increase in the MCPR is substantial. And same we have noted with PNC. And this slide was from the previous NFHS-4 data analysis, and which we showed also that how even PNC care did matter and what happened in the same set of districts when we did that analysis. So it was like a cohort. So what? We saw substantial, there is so much of positivity, positive news about the data that we are seeing, and that there is a substantial increase in the family planning. So what? What is the way forward? And we looked at from the same data that the teenage pregnancies is still a cause of concern, although there has been a decline, a very marginal decline in many states, but it is still a cause of concern. States such as, for example, Tripura, West Bengal, Andhra Pradesh, Jharkhand, Assam, Bihar, Arunachal Pradesh, they still have over 10% teenage pregnancies. And change in the teenage pregnancies over time, as you can see, there are districts which actually have 15% or more. Not just, they're not in just Bihar, Uttar Pradesh, but they're spread all across, even in NFHS-5, as you can see from this map. So while there has been some change, shift from NFHS-4 to 5, but the change, the number of districts which have this high proportion of teenage pregnancies, they're substantial. And what we try to understand, what is probably contributing to this high teenage pregnancy? And what we noted, and a very interesting finding that's coming out of this analysis, is that the districts with high proportion of young population, they reported the high rates of teenage pregnancy. And the districts with greater increase in child marriage reported high rates of teenage pregnancy. While one can say always that, yeah, if there are more number of child marriages happening, the more likely that the teenage pregnancy. But what is also worrying is that the fact that we don't consider on the volume of that adolescent population who is entering into that reproductive age, and soon after the 15, there is marriage that's happening, there is teenage pregnancy that's happening. Those are the dimensions. On the other hand, at the same time, as Nitish Kumarji says, women's education matters, and districts with increase in women's education over time reported low rates of teenage pregnancy. On the other hand, we also looked at what's happening with this whole child marriage situation. And the data clearly says child marriage declined over time, but still over 44% of the districts, they reported over 20% women marrying before age 18. I mean, we may not be able to end child marriage very soon, but from the data, what it actually says that it still currently has over 20%. And a total of 43 districts identified to have reported for over 40% women. And those districts spread in different parts of the country. And those are like those are districts in states of Bihar, West Bengal, Jharkhand, Assam, and 2 each in UP, Rajasthan, Maharashtra. While we all talk about Bihar and the child marriage, but we don't enough talk about what's happening on child marriage in other states, except in Rajasthan, of course, there are some initiatives that are going on. But what this data actually suggests is that there is a increased focus that's required. And we try to understand what actually is contributing or what is associated with this high child marriage. And what we noted was that districts with high proportion of, again, young population are the ones also reported high rates of child marriage, and the coefficient is quite large, like 1.04. And the improvement in women's education has a negative association, and that was expected, and it should happen, it should go in that direction. But worrying thing is the whole increase in that whole bulge of that adolescent population who is entering into the reproductive age. And we took the population below age 15 years as a proxy to indicate the proportion or the volume of the adolescent population. And a related data that we actually have from the census data, that the adolescent population size in different districts varies. And there are some districts in many of the states which actually has a huge adolescent population. And our Udaya study, supported by the government and the Bill and Melinda Gates Foundation and Packard Foundation, actually has informed, this is a longitudinal data, which actually suggested that the married adolescents who experience pregnancy loss increases with the age, and it goes up to even 36% of the women who married as an adolescent experiencing a pregnancy loss by the time they reach age 22 years. So you can imagine the kind of reproductive risks that women are experiencing. And we also looked at how is this shifting age at marriage from the same data actually plays an important role in delaying the first birth or even in improving the family planning use. So what the result says is that increase in age at marriage may help delay first birth only marginally, because there is a huge societal pressure to actually conceive and have a birth soon after the marriage. But what it definitely helps is the increase in the overall family planning method. So, and more importantly, I want to say that the family planning program can never rest. And last time when the NFHS-4 findings came, we presented Punjab as a model state for a variety of reasons. It's about the increase in contraceptive use, the increase in the modern reversible contraceptive methods. So for a variety of reasons, we presented Punjab as a model state. And when we look at the NFHS-5 data, we were quite taken aback, which means that while we need to really understand and explore this in detail after having the raw data, but what it indicates is that there is a 15% decline in modern contraceptive prevalence rate in the last 5 years. While prevalence of all methods decreased, condom use has increased, which is making it better method mix overall. However, it is not overall better method mix, but method mix dominated by condom use and the sterilization in Punjab. But the other methods seem to have taken a hit. So what this finding actually is suggesting the possibility or the fluidity that exists in the whole family planning use behavior for couples across the country. And that's something that we need to take care. And we further went into doing the analysis of those district level data. to understand the overall program performance, not as a family planning program performance, but as an overall RMNCH program performance. And how do we define the districts where there is that more attention is required? And we used the India level cutoff to define on the indicators, and these were the critical indicators which were significant in our previous analysis, and hence these are the indicators that were selected. And we looked at that data, and there are about 157 districts which says that those are the districts which are lagging behind in the performance, overall RMNCH performance. I'm not talking about the family planning, but overall RMNCH performance. And when we take this and add the nutrition variables to this data and use the latent class analysis, then what we arrive at is the, including the nutritional indicators, there are about 176 districts that come as a major geographic areas of focus. So with this, I just have these two key learning, the key takeaways slides. And one slide is on the learnings. What the whole data is suggesting is the contraceptive use has increased substantially across the country. We all know that. An increase in contraceptive use is also attributed to increase in reversible contraceptive methods, which is also helping balance the method mix in some states. There are still some states which have the very skewed method mix, and that's something to understand, whether it's the women's choice or whether there are other reasons that are actually making the states continue to have the skewed method mix. The other important learning from the data is increase in health worker outreach to female non-users and quality of care seem to play a significant role in both adoption and continuation of the contraceptive prevalence. And the third major learning is that the attention of family planning program using strategy like Mission Parivar Vikas, which actually has got a lot of the programmatic attention, intensity, monitoring, and many new methods, initiation, and providing improved access, made an impact in districts which were otherwise not performing so well in 2015-16. We don't have the fertility data for those districts in order to actually see whether that resulted into substantial decrease in the total fertility rate in Mission Parivar Vikas, because that was the major indicator that was chosen to define the Mission Parivar Vikas districts. But what the data is suggesting is that redefining the districts of focus and sustaining the gains is critical at the moment. And the way forward, the three key takeaways for the way forward. One, increase in traditional method use is observed in several states and districts, and the change is coinciding actually with the increase in reversible contraceptive method use. So, and research, actually past research using the NFHS-4 data and the previous rounds showed that method discontinuation issues emerge or result into adopting to more of the traditional method or non-use of the contraception. And those are the method discontinuation should become the focus as the India is going towards balancing the method mix with more increase in the reversible contraceptive methods. The second way forward is the districts with high proportion of young population are lagging behind on many indicators, and that is the result that we have seen. The child marriage, teenage pregnancy, contraceptive use, maternal health, and several districts actually in the country have more than 1/5 of its population in the adolescent age, who are entering or entered into the reproductive age group. And those districts require a very well thought of strategy from the family planning perspective, or even RMNCH, which embeds these elements of child marriage, teenage pregnancy, and maternal health. The other way forward is insights from these data suggest that there exists that fluidity in the family planning behaviors. For example, some districts across the country have shown the decline in contraceptive use. And there are also the districts which actually have shown that the different the change in that contraceptive method mix from what existed in NFHS-4 has actually changed in NFHS-5. So there seems to be some fluidity, I mean, which requires actually further research by analyzing the data, the individual raw data. But what the message is that the family planning program requires much more attention in that overall health mandate, because we can never rest about when we speak about the family planning. Thank you so much.
Thank you so much, Niranjan. This was a very interesting and comprehensive presentation. And thank you for highlighting that the business is not done yet. I hope this presentation was helpful for the participants. We have questions coming in. I will request the participants to keep sharing their questions. They will be answered in the Q&A round. Our next session will be a panel discussion where we hope to discuss the implications of survey findings on policies and programs. The panel will be moderated by Anand Sinha. Anand is the country advisor of the David and Lucile Packard Foundation. He has more than 2 decades of expertise in public health. We also thank Anand and the David and Lucile Packard Foundation for their guidance and support to our coalition, for which we are very grateful. Over to you, Anand. May I request you to please introduce the panel? Thank you.
Thank you so much, and thank you for inviting me to be part of this really important meeting and discussion. So I have an extremely illustrious group of panelists who are going to help us understand this data a little bit more. And thank you, Niranjan, for that. Wonderful, I think, very rapid overview. There's going to be hundreds of questions coming in as we will try to get to. So do please keep your questions coming in on the chat. So the panel today I have is Dr. Rajan. Dr. Rajan is the chairman of the International Institute of Migration and Development. He's got more than 2 decades of experience of sort of bringing on-ground perspective and a deep understanding of population dynamics and population changes and trends in India. Poonam Mutreja, who is again member of ARC and executive director of the Population Foundation of India, has many decades of experience, has led a number of large and founded a number of large and illustrious organizations working in the field of gender, health, and rights. And then we have Abhijit. Abhijit is the senior program officer leading the family planning program at the India Country Office of the Gates Foundation. And again, he has several decades of experience working in this sector. So really people with a lot of experience and a lot of ability to sort of, I think about this data and help us understand it a little bit more. I'm going to start off first of all, with sort of big questions, and as Niranjan was sort of presenting this data, I was thinking back to we always sort of say the purpose of working in the development sector is eventually to lead ourselves out of a job, is to do ourselves out of a job, because we should solve the problem, and I wonder whether we're eventually getting there, and we're making substantial progress that actually helps us. But again, I think the case of Punjab sort of sends a message that maybe our work will never rest, and we will have to stay on this treadmill for a long time. So Dr. Rajan, there's a lot of good news coming out of this. It seems like India is reaching towards the replacement level, fertility replacement level, and of course there's a lot of variations amongst states and different districts. So I guess the first question is, what are the long-term implications of fertility declines for states which are at different stages of their demographic transition, and what do we need to prioritize in the population field, given that the country seems to have reached that replacement level? So what needs to change? The assumption is that we will not continue doing the same sort of strategy of family planning and addressing the population dynamics as we have been in the past. So what should we be thinking about in the years ahead?
Thank you, Anand. Thank you, Anand, for the question. I think let me start saying that I think the long-term implications of this trend is something we should worry about that. Because people think, especially the policymakers and even politicians, think that we have achieved 2.0, the matter is over. But I think that this is where we should not celebrate this. I think our job starts now. We have to do more work, because what we have done is some type of what is called the quantitative business on reducing fertility. But quality-wise, I think we have to do a lot of work. For example, look at the low fertility. We are talking about 2.0 now, but the stabilization will not happen for at least next 30 years. Because when I came to Kerala in 1987, the TFR was less than 2.0. Still, we have not stabilized. It will go for another 10 years. That means there will be a huge population momentum. So we have to look at that. The second point is when we talk about fertility, I think we are forgetting something about infertility in this country. I think, I don't think that the program is just to stop fertility. I think the program also should play a major role in see to it. There are people who are not able to have children. We should look at it, because when some of the database people talk about in the state where I come from, Kerala, almost 1 out of 10 couples are not able to have children. If this is correct or this is overestimated, I don't know, because we have no data on infertility, because fertility is the other side of the story. You cannot talk about only fertility. So I think we should talk about infertility and also the implications of low fertility. In fact, I think now time has come, we should concentrate on low fertility district. What to do with this district, what can be done, because I think otherwise you are going to end up saying that we have achieved, now what to do. I think we should think of like a special focus districts on the low fertility and what are the long-term implications of low and the lowest fertility. We are talking about 1.0 in some places, not 2.0. I think it is going to have a huge implication. Family, arrangement is going to change. So the long-term implications of fertility too, we should look at it. The second point, which is also important in the limited time, is that we all believe, I think we are all wrong sometimes. Population policy means we talk about only fertility policy. It is extremely wrong, because population policy includes fertility, mortality, and migration. Please remember that. I think people, you look at the population policy of India, I don't know, every country, every state talk about reducing fertility. What about migration? Migration is going to be the component which will be very active in this country. 600 million people in the country are living in a place they are not born. Or is part of your population policy? Very important, because there will be states, for example, state like Kerala, we don't need to export people from Russia. We can export people from other states. So I think this demographic dividend or the low fertility is very good for us, because we can move people between states. We don't need to worry about the labor scarcity in states like South India and other places. I think we have to think seriously that population policy means not like a fertility policy alone. This is also important, because many times people think that family planning. I think that we have not done more work on family welfare still. We are still talking about family planning. I think we have changed the title of the department and the ministry, but I feel that we have not done more on the family welfare. We are only talking about family planning. I think welfare is not coming in a big way. If you look at some indicator, which I'll tell you probably in the next part of question, but I think the welfare has not come in big way in terms of nutrition, in terms of women literacy rate, in terms of women's employment, in terms of, for example, mean age at sterilization in this country is less than 30 years. Now, what are these women going to do? They have just one child. I have seen in Kerala, 20% couple is stopping with one child. What are you going to provide the space for the women to do a productive work after that? I think we have to think beyond this fertility. I think time has come. We should stop talking about fertility decline. We should think more about quality of life for those limited children, whatever children we had, 1 or 1.5 or 2, but give them a good quality in terms of nutrition, in terms of education, in terms of employment. Otherwise, whatever we talk in a big noise about demographic dividend, I think it will be a demographic disaster for India.
Thank you so much. Thank you. And I think you've raised some really important points, Dr. Rajan, there, because I think that, it is, I think data like NFHS does help us understand where the trends are changing, and maybe some of these, significantly larger changes are needed in terms of how we think about what the actual problem is. And I agree entirely is that the problem should not just be seen as being one of fertility or fertility control. Poonam, coming to you. The question was, what are some of the factors outside of the health system that need to be emphasized if we want to sort of address the barriers that women and young girls or adolescent girls face in accessing family planning services? I mean, I think we've heard a lot about how we've made progress with respect to frontline workers and connecting with the health system, and that is obviously a big contributor, as well as investments in maternal health support. But beyond the health system, I think, what else do we need to do to sort of, again, try and improve access for women and adolescents?
So thanks, Anand, and it was really helpful to hear from the presentation on various aspects of young people, even though young women, you're talking about girls and women, but girls, there isn't so many questions and very little in NFHS, unfortunately, for information on adolescents compared to others. And I want to start by saying we need to do a lot more in NFHS-5, given the large number of young people that we focus on adolescents. And it's very clear when we talk about young people from Niranjan's presentation, as well as analysis, there's been some improvement. So there is a feel-good factor, but अच्छे दिन नहीं आए हैं अभी. It is just a slight feel-good factor. We were in a very bad, negative space 20 years ago, 10 years ago, became better. And in the last 5 years, it's definitely improved. But given where we began, if we just look at percentage terms, like I want to use injectables as the example, where we show 3 times increase in injectables, but it's only 1% of the contraceptive basket. So, let's not become complacent, or let's not get overexcited, and all this thumping of the chest that the media somehow got into. Maybe they were desperate to show they were अच्छे दिन, but I'm not feeling that. So some of the big, the key areas where we need, outside of the family planning, outside of the health system, where we need to keep the work going is clearly, first is comprehensive sexuality education. You want to change the title. You don't want to use the word sex in this period of time. I think we need a separate discussion on that, Anand. And this is something that Packard as a foundation and Gates Foundation should be, since you're the two foundations here, I'm addressing you. We should be looking at it comprehensively. Are we going to keep talking about comprehensive sexuality education and lose the opportunity because we use the word sex? So, but it should definitely be made mandatory in schools and out of school, for especially out of school young girls, and used as a tool to empower adolescents and youth, especially girls, in order for them to make informed decisions. Clearly, young people have less access, the data clearly shows. Investing in gender equality initiatives is equally important, and early and forced marriages cannot be dealt with only in terms of marriage, but it has to be dealt with a broader gender equality initiative. I keep saying, I keep hearing from people in the community, child marriage is a solution. It keeps our daughters safe, and we all call it a problem. I think we have a long way to go on understand, locating it in broader gender equality, and not just issue of age at marriage, which we do have to work on. And we need to talk about age of marriage, not only to postpone the first child of fertility, but it is we need to look at it in a girls' empowerment framework, to keep them in school, to keep them in the workforce, to find opportunities and pathways for their workforce participation. Investing in secondary school education of adolescent girls. Yes, there have been improvements, and the very colorful, nice data that we saw also shows that 1/5 girls, 1/5 girls marry early, and these are all girls who are out of school or get out of school. So keeping girls in school and investing more money in the safety and all aspects that are barriers for secondary school education for adolescent girls. We need to work on. Evidence suggests that allowing girls to complete the education delays marriage, delays pregnancy, provides them opportunities for financial independence. Yet, according to NFHS-5, less than only 41% of women aged 15 to 19 years have completed 10 years or more of schooling. There is then, to fulfill their aspirations and have a life of dignity, that has to be our goal for for women and girls in India. And finally, my favorite, but I'll spend a line on it only since I've taken a lot of time, which is changing social norms through targeted social and behavior change communication to address first false notions of masculinity. And if there's anything NFHS further confirms is the burden has increased on the women, and men continue to not see family planning or promoting values of girl child or caring for children, leave alone pregnancy, leave alone not being, they'll never achieve the possibility of getting pregnant, but surely there can be increase in child rearing, child caring, and participating in family planning. So masculinity and issues around that through behavior change communication, along with many, many other things can be done. Thank you.
Thank you so much, Poonam. Yeah, there are many things that do need to be done, and I think it's that's abundantly clear from that. But I think that's a very comprehensive sort of view of what else is in the surrounding environment that needs to be addressed. Abhijit, what we've seen that, you know, there's been an improvement in family planning counseling. There's been an improvement in outreach by health workers, by frontline workers, and we're seeing that that's obviously contributing to an uptake. But the uptake, and while I didn't fully understand the data, but I think while we've seen an uptake in overall, you know, in reversible methods and in non-reversible methods, the uptake or the, you know, increases in the reversible methods has not been as significant, or it continues to be a small proportion of you know, of the entire method mix. Now, given the fact that, you know, we're still talking about the needs of, you know, young population and India sort of, you know, large youth populations, what do we need to think about, or what do we need to be doing to sort of address the needs of young, you know, of India's young population, especially given the fact that we've not seen, you know, significant proportion of uptake in terms of reversible methods? But I guess the question is, you know, what, I mean, I think, and Niranjan has pointed to it fairly clearly, is that, you know, youth and, you know, adolescents will continue to be, you know, a focus of attention. So what should we be thinking about in the way ahead? And how does this data sort of maybe change our conceptions about what to do with young people?
Thanks, Anand, and actually thanks to Niranjan. I'll that, you know, his last slides, those 6 bullet points, really sort of help us take the discussion forward. So I'll pick on some. Thank you, Dr. Rajan, for you know, bringing up the nuanced difference between contraception and family planning. And very often we hear that, why don't we replace family planning with contraception if that's what we mean? But you brought out why we shouldn't, perhaps. But to come to your question, and thanks, Anand, for raising the question in that manner, because I think what the data now points out to is something that we all did actually many years back. And I can talk for the Gates Foundation. As most of you know, when we changed the strategy and pivoted to a focus on only reversible methods, only younger and lower parities, and absolutely sort of withdrawing from our support for, you know, sterilization or some of the earlier parts of the program, we faced a lot of questions. We had a lot of effort to convince. And I think now, at least with the second NFHS data here, there is sort of a validation that this was needed. And so one of the things that we should all agree on, perhaps in this forum that ARC has given us, is that now is the time to look beyond the averages. now is the time to make the family planning program an equitable program. And by equity, I mean the age segregated data of the same averages we saw, parity segregated data of the same averages we saw, vulnerable populations and districts which are backward or tribal or consist of the poorest of the poor as a large part of that cohort. We should look at that. So I think equity should become a focus, and that's why I like the way you positioned it for young people, because once the data is sliced and diced, we will see that the picture isn't as rosy for the newlyweds, for the part that we call demographic dividend. There continues to be significant barriers to access family planning. There continues to be significant unmet need in that young population. Now, what should be done? I'll just pick out very quickly 3 bullet points that Niranjan said. So he has given the data. But I think one of the things that is extremely important is look at the contraceptive prevalence mix. The fastest growing method and the most popular method in India for the last 2 NFHS rounds actually is traditional methods. And how long is the family planning programming community and the donor community, in fact, not address traditional methods? And we need to look at it. We haven't had programming, and I count myself as one of them. I'm looking at it very keenly. The second part of the contraceptive mix is essentially, for the first time, I think, at least in UP, there has been a dip in female sterilization. There's been a dip in sterilization in general. And for Indian average, there has been a plateau. Again, this changing method mix, coupled with the observation that Niranjan told us that Mission Parivar Vikas districts have given more than double the performance of non. So what was the central pillar of Mission Parivar Vikas? It was new method introduction. And that sort of points to the constrained basket of choices that we have. Is there a solution there by expanding basket, by adding more and more new methods? It is sad for us that countries like our neighboring countries in the region have a wider basket of choices than we do. So adding more products to the basket will probably bring in young people, would be a hypothesis that I would propose. The second thing is the ASHA contact. Now, like Poonam said, a lot of chest thumping about, going to 23%. Now in UP and Bihar, we have gone from 12% outreach and 10% outreach to 23, which is the country average. But I'll flip this. 23% of FP outreach means 3 out of 4 women will tell you nobody came to them and talked about family. And if I cut and slice this to young people and newlyweds, I'm sure it's even worse. So 1 in 9 newlyweds would have been approached by somebody to talk about family planning. And couple this with the sort of needs of this age cohort. NFHS this time has even captured mobile phone use and internet use. How that grows in this? Can we leverage new technology to supplement the outreach that the ASHA does? Can we use other forums, ARC, SK counselors, etc.? But I think outreach for family planning is my second suggestion. And the third big suggestion, which I think Niranjan showed a graph but didn't speak on, was that traditionally in this age cohort of young people and newlyweds, the channel of choice has been private sector. Now we still remain to see how the district-wide variations, private sector participation, etc. has happened. But I think there is a huge need to re-galvanize some of the programs that traditionally we used to call private sector engagement programs, such as social marketing, social franchising. All of them are at a point where we are reimagining what they could look like. If we can reimagine them with young people in sort of at the center of our focus, maybe these 3 would be sort of my sort of go-to suggestions, but still to be waiting for the sliced and diced data from Niranjan. About the reversible contraception, I think we can talk more about that later. But yes, there are some good observations there as well. Over for me.
Thank you so much. I think those are great suggestions, and I think this is a question I'm going to ask everyone. Is there is a need to slice and dice this data more. There is at an average level, there is a tremendous amount of good news, and the agenda for the coming years will get will be formulated once we look underneath at sort of deeper layers of the data, and we've heard I think some questions already coming in about sort of what might be some of those analyses or those bits of sort of deeper diving that we need to do to understand issues like quality, understand issues like inequities or equity of improvements that we are seeing, whether it's by population or by other factors. I know that is something that we are interested in. I'm going to open it up to some of the questions we've received from participants so far, and then maybe I'll come back for more questions just because I am sensitive of time. I think there's a couple of questions, and Niranjan, and I mean, a lot of them are aimed towards you, but I would just encourage everyone to come in. So one of the questions I have myself, and you didn't talk about this, Niranjan, specifically, was the sex ratio data, which shows, that there have been some data interpretation shows that it's been improving, etc. And I know that's been a topic of discussion amongst a number of people in the field. Can you tell us, tell us what are the headlines on the sex ratio data coming out of NFHS-5, and what is possibly the explanation behind it? And I'd love to hear from others as well on the panel on that.
I mean, in fact, Dr. Rajan is here. He might be able to contribute to this discourse more. But my take of the sex ratio data from the NFHS-5 is that we should not read too much into that, on the specific indicator of sex ratio for the overall population. The reason why I'm saying, and which requires actually more deeper analysis before we come to any conclusion, is because the sex ratio at birth, that the sex ratio 5 with it, I mean below the age 5 years of birth, sex ratio at birth indicator has moved only the 10 percentage points, whereas the sex ratio of the overall population actually shown as moving 35 to 40 points, which is an impossible thing to happen unless more men died because of the COVID or for variety of reasons, or that there are maybe some other reasons that includes perhaps migration, which is not actually where the households in the surveys are actually not reporting the men who may be working outside or some other places. So that is something that is a close investigation. That's one of the reasons. Many journalists contacted me to comment on the sex ratio, and I said, this is unless we have the complete data, we cannot actually comment on it. And the more important information is to get from the census and not so much from the NFHS data. But maybe Professor Rajan may have some comment.
Yeah, I just want to pick it up from what Niranjan read. I think one of the things is that, first of all, NFHS should not have published the data itself. I think the indicator they should not have published. I think they did a mistake because you are supposed to produce a good data on family health and family welfare, a child thing. But you are not doing that. I think first of all, the general population data, I don't think they were published, but I don't think anybody should look at no headline on that. I think that is something very important. The second point, in fact, I would also again go against even using the sex ratio at birth, because even that has problem. I don't think we should use it there, because you look at the data from the NFHS itself. I have a data which says 90% of the children were born in registered institutions, either private or public. And birth registered during the last 5 years, 90% of the births in this country are registered as per the NFHS. If every birth is registered, why are you looking at the NFHS to look at the sex ratio? You can go to the CRS. There is a huge data you can do by village level, taluk level. I look at it in Canada. Why are you looking at the NFHS? These 100 to 1,000 households in the district. I think both the debates should not be part of the discussion, because I don't think NFHS is meant for producing reliable data on either sex ratio at birth. But I question even the SRS should not produce that sex ratio at birth. So I think they should not do that, and diverting the attention which is not required. And every newspaper is having an article on that, which is a waste of time for them as well as for us.
Anand, can I?
Yes,
yeah, so, even if you look at the number they've given, data showing that there are, NFHS-5 data shows that there are 1,020 women for every 1,000 men. And most likely, this is an overestimate and does not represent the actual figure. even according to many of the population scientists. And this is an unexpected trend, which needs further evidence. And as I totally agree with Dr. Rajan and Niranjan, we have to look at the census data for this. And in fact, the media did chest thumping, and people went congratulating the country and got very excited on this, even though the additional secretary, Health and Family Welfare, warned on the very first day that we have to wait for the census data and we can't look at NFHS data. And more recently, I don't know if any, some of you have seen in the Financial Express, I think, there is a quote from Dr. James himself, who is the director of IFPS, who has shared that they did not include the army data, they did not include, armed forces data, homeless and army personnel and hostel establishments. And most of the people are men in the army, a large percentage. So there could be, many reasons, but why? But I think we should just wait, and we shouldn't accept this as the real data.
Thank you, Poonam. And I think that's a resounding message from this, from this group of experts is really just, hold off on jumping to the conclusions about sex ratio on the basis of the NFHS data as of now. I know it's of extreme interest to a lot of people, but I think it's, the message is quite clear, is that don't sort of, jump into that. And I think that's particularly important for this community, that's listening in here with interest in reproductive health and reproductive choices.
But Anand,
yes, ma'am.
Sorry, I just want to say one thing. The thought is very nice to have more women than men.
Of course it is. Of course it is. But it's hard to believe, I think. And that's unfortunate. As it
Sorry, I interrupted you, but I
No, you didn't. There was another question on just help us understand the increase in traditional method, in use of traditional methods coinciding with the increase in reversible contraceptives. Broadly, I understand that, but I think there was a question saying help us understand that a little bit more in detail. Is there a dropout from reversible method, or what is leading to that increase in traditional method use?
That's right, Anand. I think that is the area of, like Abhijit said in when he was briefing, what he mentioned was that over time we have been seeing that increase in the traditional method use. It's also coinciding with the reversible contraceptive method use increase. And the detailed analysis of the NFHS-4 data, because right now what we have is the aggregate numbers, and we were trying to make a meaningful interpretation of the aggregate numbers. But detailed analysis of NFHS-4 data had showed the contribution of the past users to the total unmet need. Because of the reversible contraceptive methods is much more significant than those who are not using any method and the unmet need. So which means that there is a couple who accepts a particular reversible contraceptive method is more likely to either switch, which is very less proportion actually switch to other method, rather more proportion switch to the sterilization. And in that process, in between, there is this whole increase in the traditional method use acceptance. That is where we are saying the reversible, with the more increasing young population coming into the reproductive age group, there is more appetite for reversible contraceptive methods. And as the appetite for reversible contraceptive method use goes up, the need for facilitating the switching and supporting the continuation of the reversible contraceptive method use is very, very critical, and the interventions need to think very creatively in that direction. Otherwise, we'll continue to witness the increase in traditional method use over time going forward.
And Sita has just a follow-on question from that. She's saying, just help us unpack traditional method use. Is it indigenous, Ayush, natural family planning methods, which are the most popular ones?
Well, I think it's more of the withdrawal method, and the NFHS survey actually has a very standard definition of the traditional method use that encompasses the withdrawal method and the use of, safe
The
period.
standard days method.
Standard days, yes.
Thanks.
So that's what I was referring to.
There's a couple of questions related to migration and just helping us understand migration a little bit, and maybe Dr. Raj can take some of this, but also to other people in the panel. I think there's one about, is the increase in condom use related to migration, migration trends? And I think the other question was interesting was that, is the declines in Punjab in terms of, contraceptive use, etc., because of in-migration? I mean, people coming from other states into Punjab, looking for work, etc. Are those sorts of things, leading to any of these changes? I guess, just help us understand a little bit more about migration, because I think migration, Dr. Rajan, is important as a population dynamic in terms of it's about people moving from one place to the other. But does it also influence, reproductive health choices, family planning, contraceptive use, decisions about family size, all of those? I think, we're seeing more and more data emerging on that. And I think just to unpack migration a little bit more would be helpful.
Thank you, Anand. I just wanted to, before getting into migration, I want to talk about the method mix. I think that one of the things is that I think if the country should not focus so much on this, what is called the sterilization business. I think we have to divert the attention. We should go back to the cafeteria approach. So if that is declining, I think it's a good news, because we have to get into other methods, because a lot of people talking about sterilization regret in this country. We are not talking because somebody has just one child, the child had a fever, at the age of 10, the child dies. I think we have to look at it. That's going to be a huge topic, like infertility. There are people I have seen in my own village, somebody had 2 children, both of them died. Now they were, the whole family, the whole area, they're telling, we told you not to go for sterilization. I think this is going to be, when you have a low fertility, and I think this is something we should really do studies on that, sterilization regret. And the second point along with this thing, because I also see, because I'm sitting in Kerala, which is called a modern state or modern thing, abortion is picked up as a contraceptive. I don't think people are talking about it very seriously. Because I see when I talk to couples in Kerala, this is like a modern woman. Like, you marry late, have the first baby immediately, between the first and second, you have one abortion. Now, one abortion is it a normal thing? This abortion is used as a temporary method, and then they go for second baby, and then they are sterilized, what I call them in Kerala, 2-in-1. They go for sterilization and the delivery of cesarean. So they go one time, finished job. I think this is something, a bad trend. If the abortion is used by the couple, especially the so-called modern couple as a contraceptive, we have failed in providing contraception. I think we have miserably failed. If a couple are not getting that and they're going for abortion, which is much more serious. Because I know that we never talk about what happened after the childbirth, because the MCH program concentrate only for them up to the women. We never talk about menarche to menopause. We only talk about childbirth is over. I think we leave the women after that. Once she is sterilized, I don't think any health worker goes to them. I think this is a very bad thing. Emphasizing so much on women, when the job is done, we don't care about that. I think that is something we have to change, based on the NFHS data. Now, regarding migration, see, like abortion is a contraceptive, migration is also a contraceptive. Please remember that. Because I was sitting in Kerala, I was sitting with the state demographer in Kerala, and they told me the couple production rate by district. And they said that Malappuram is very, very low couple production rate. We should do something special. I said, don't do anything, because 1 million women in Kerala, their husbands are away. Out of 5 married couples, 2 couples in some places in Malappuram, husband is away. Husband is away is a contraceptive. They are away for 2 to 3 years, not internal migration. So we are talking, they can come only once in 2 years. I think this is a huge thing. And either we have data on migration, first of all, we have nothing. Numbers are floating around in the country. And second thing, we don't have many analyses. Even NFHS cannot do analysis by migrant, non-migrant. They have not even a single question being asked. NFHS, that's why I remember when the NFHS first came out, National Family Health Survey, number 1 and 2, I criticize the NFHS. Because they put National Family Health Survey, they think family health includes only women. Where are the men? Until NFHS 1 and 2, they never asked a single question to women. Family means not just women. I think this is a wrong concept we are talking about, that family means only women. Where are the men? So NFHS 3, they started asking questions. They were very upset when I asked this question, but now I am glad they're asking questions to men. You have to ask questions to women. Then you don't tell them that they don't participate. You don't participate with them. Even a big survey like NFHS is not even up to the men. I think we have to change. I think the migration data differential, we should look at it very carefully. It will open up a lot of Pandora box.
Yeah, yes, Niranjan.
Just a quick point on migration, because that is going to be a significant implication in the planning program going forward. The one is that this whole change in the method mix, and we did this study which Packard Foundation, you have supported us in Bihar, which actually had shown that the couples are couples with who have the migrant, women who have the migrant spouses. In those couples, so much of fluidity in the way they use the contraceptive methods, in which means that even that change that could happen in a very short period of time. When the man comes back home, there is no contraception, absolutely. And then immediately they start thinking about, oh, the pregnancy risk, and then they go for using some method or end up having the medical abortion. So there are those implications that are not, well, what we are seeing and what we saw from the NFHS-4 data is that in the places of origin, I'm not talking about the migrants in the destination area, but in the places of origin, the women who have the migrant spouses working outside actually had, in those couples, the modern contraceptive prevalence rate was significantly lower as compared to the women who have the non-migrant husbands, so the resident husband. So that's the kind of data that we are seeing, and we are waiting for NFHS-5 to come. And there are a lot of interesting questions that came up in the chat box, which actually talks about whether this whole condom use, the increase in condom use, is attributed to migration, and that maybe, and I was looking at the slide to really make out of it, sense out of it, but it is, that's an interesting question to look at, actually.
Abhijit, you have your hand up, so I'm going to come to you, but I'm also going to pose this question that has just popped up in the chat box, saying the issue of indiscriminate use of emergency contraceptive pills needs to be deliberated. I'd love to hear your viewpoints on that, but first of all, make the point you were going to make.
Yeah, actually, I was going to make a point related to that, and that essentially is, while we will wait for more data, like Niranjan said, raw data to come in to do some of these analysis, what does these seemingly separate sets of data tell us? Migration as an issue and as a data set in itself, abortion, whose estimates we don't get frequently, the last reliable estimates that we have, condom use, emergency contraceptive sales. By sales, I don't mean survey community data, but market data. Gartner, Forrester will tell you how much of that happens, medical abortion sales, etc. And all of this now mixed with, this is the year where second edition of the WHO self-care guidelines have come. India has a self-care product registered in the private sector at least. In the paradigm of self-care, looking at all of these data together, the word that Niranjan used, fluidity, I would take it further and say we need to question our definition of continuation rates themselves. What is continuation? If we are to subscribe to the notion that women should have an expanded basket of choices and all their choices should be treated as an equal, then really we need to question the idea of continuation rates and go to a client-based format of studying. Now, the traditional ways of approaching from service statistics or HMIS does not tell us these client journeys, this fluidity that Niranjan talked about. But I think we need to look at contraceptive journeys of women and whether our notions of continuation rates, discontinuation, etc. in a self-care paradigm even make sense. Over.
Thank you so much, Abhijit. I think that's such a valid point. It's such an important point, is that as we look at these changes in the landscape, our assumptions of attributions that they lie within a certain trajectory of health services provision is so flawed. And you're right, there are so many other data sets we're looking at, the market, abortion, self-care, as being mega trends that are changing the entire landscape. And the assumption that we should still be sort of tweaking around with like, method mix and, permanent method and reversal method as being like the big equation to be solved is extremely, I think, short-sighted. So I can't agree with that more. And I would caution, I think there's a technical point to be made about the term indiscriminate use of emergency contraceptives. I don't believe there's any such thing as indiscriminate use. You can use emergency contraceptives every week of your life if you want to, and there's nothing wrong with it at all. And the WHO says so, not just me. Sorry, Poonam, I know you had your hand up as well. I don't know if you wanted to make any points. Sorry, Poonam, your mic is off. You're on mute.
I wanted to respond to your question on migration.
Yes, please.
And it's a technical question. Actually, in answering, I'm asking a question from Professor Rajan. Migrants are not included in the surveys, whether it is census or in NFHS, right? So, if that is true, and that's what I believe is true, then your question is irrelevant in terms of, is it because of migration? Has the couple protection rates increased in Punjab, decreased, sorry. And second, I want to say to Niranjan, I love the use of resident husband. This is a new, it makes him feel like a temporary, visitor who's residing in your house. I think it's very empowering. It's a very empowering statement, and I intend to use it a lot. And finally, on abortion, Dr. Rajan, it's not just women don't have one abortion they marry late, have one abortion between first child and second child. The average number of women, many women, have multiple abortions. I mean, I don't know what is the latest data, and Niranjan and other on the panel and Anand might be able to tell us, but the last data that I know is that 77% of women who go through sterilization have never experienced family planning ever, any temporary method. So perhaps the figure has changed now, and we should find out what the figure is, and let's hope there's a marginal feel-good factor there also. But Achhe Din for women will only come if they stop having to use abortion as a proxy for contraception. And at this point of time, whether it's medical abortion or it is surgical abortion, much of the abortion is a proxy for contraception. And while I'm absolutely for abortion as a right for whatever reason to have an abortion, but it's fine for women to have as many abortions as long as they are safe and they are okay, and clearly medical abortion to an extent is safe. But I think this is something we need to look at, and we perhaps need a campaign to stop using, for women to have to use abortion as a proxy for contraception.
Thank you so much, Poonam. I think that's a really important point, and we need to conclude now because our panel members need to, I know many of them need to leave on other things. I'm reminded in this discussion of the game Whack-A-Mole, which is basically that this little mole keeps on popping out and you hit it. And when you hit it and you think you've won, it pops out of another hole and there's a new problem. And this is what is a Whack-A-Mole. I think the other perspective to remember is that we're not just playing this one game Whack-A-Mole. If you want to address the issues of women's needs and families and population, there are many other games which are beyond this frame. And I think that's, again, one of the points that we're talking about. Thank you so much to the panel for this. Over to you, Bijit.
Thank you so much, Anand. While this webinar has clearly shown while there has been so much progress, there's also so much of business at hand. And 5 clear things have come out from the panelists and the panel discussion. The first is around strengthening community outreach, improving equity, and reaching out to vulnerable. Specifically, reaching out to non-users with information and services to initiate family planning. The other point which came out clearly was, how do you provide information to women and men on side effects of contraceptives, especially to ensure that there is continuity and there's high uptake of. The second thing which came out from most of the panelists and Niranjan did talk about was more focused interventions around gender equality. Keeping girls in school, improving age at marriage, addressing teenage pregnancy. The third thing which clearly came out from the MPV districts, and Niranjan, thank you so much for bringing out these learnings, is there has to be more focused, localized planning and action. And 104 districts actually need a lot more attention in terms of improving the MCPPR, working more intensively with young people. And these states are primarily located in the north, the eastern and the northeastern parts of the country. There's a lot more work that needs to happen on quality of care, and also what would be the implications of low fertility, especially in states like Kerala and Sikkim. A lot has to happen in terms of the way programming is being done and care for the elderly. Thank you so much, everyone. Anand, a special thanks to you for moderating the session. Our panelists, Niranjan, thank you so much for the wonderful presentations. Our wonderful panelists, Abhijit, Dr. Rajan, and Poonam. Thank you to all the ARC members, the CSO partners, the media representatives who have joined. And last but not the least is thank you to the Population Foundation of team and the Secretariat, wonderful team of Negi and Rizwan for providing all the technical support, Deepa for your help and guidance, and Ishita and Gopi for being on top and communicating it to a wider range of audience. Thank you so much. Thank you so much.
Thank you.
Thank you.
Thank you. Thank you so much.
Thank you. Bye-bye.
Thank you.
Thank you. Thank you. Thank you.